we decided, this is like just preamble, so
Okay.
we decided our group to like go pigtail and we like, and to just use that because it's just so much easier.
Wow, that's great.
The group felt comfortable. And I think it's just easier if you, especially with a rare procedure, if you only have one procedure of the rares, right? So I do really like it. Maybe I'll just, we can open this, right, and just look at what it looks like. So if we think of our...
We can even use that, that is no raw.
Yeah. Okay, so if you dump out the stuff.
Almost unpassed it.
So the Seldinger technique, right, it's like a multi-step technique where you're gonna over a guide wire, right? So that's sort of why this is like a nice technique. So it's safe because you're inserting.
We just started making it. Yeah, that's
No, you're good. You're good. All you missed is that we're doing pigtail because that's the best one to do.
Okay,
Yeah.
sure. Can you do
It's the only one we know how.
It's the only one we know how. Yeah. Yeah. So you're going to end up putting this guide wire in and then putting everything over top. So this is just essentially the guide wire is just sitting in this tube because it isn't flying all over the place and likely to get contaminated. And this, it's got the curve at the end so that when it's in there, it isn't puncturing anything. But you're going to have this supporter or this extender going right to the tip when you put it in. So, and anyway, so that's in there. We've got our needle, which is going to be the first step, of insertion. We've got, then you're going to stick your wire in. Then you're going to, this is our dilator. This is the actual chest tube that also curls. And then this is beyond me. This is the nursing piece. This is what we're going to use to attach.
There's no nurses in this session, is there?
No.
So I probably won't focus heavily on the
So we're
nursing
going to
aspect of it.
start yeah.
Okay.
I'm Kelly,
Yeah.
one of the pediatricians.
Oh, I'm Linky Wannabe. Nice to meet you. I'm a family physician.
Oh, awesome, cool. Lisa and Jill.
Hi, nice
And
to
we're heard
meet
you're
you.
like really nice, so we're, you're really nice to us. That's the only requirement, pretty cash. Okay, so just to sort of set it up, this is the situation that you had this baby, term baby born. They maybe needed a bit of resus and you bag them and you do a chest x-ray after and you notice they've got a pneumothorax. You probably called PTN and talked to some nice intensive or NICU doc who said, hey, just why don't you throw in a pigtail? And you say, sure, no problem. They just taught us that last week, so I'm good. Obviously, the patient is stable for this chest tube insertion. Because if they're unstable and you need the quick, then you're just going to do the anterior needle aspiration, which you can just use any IV catheter.
We use the Netzivas.
Yeah.
Right, the
Now.
Netzivas, right.
Well, yeah, we do.
Yeah,
we do,
I think
right?
most recently, although I'm always intimidated by this, I'm like, just give me a regular needle. But this actually is better because you can close it and repeatedly aspirate, and it's more likely to stay in versus the time. If you just use like the other guys, right?
Yeah.
And so for insertion of this guy, right, you're just going, mid-clavicular line, second or third, cleaning the area, putting it in, aspirating. That's something we can totally try on the chickens, right? So that's a good thing to just practice. The only thing about the chickens is instead of actually where you would put it in on the baby, you just need to find a good spot between the ribs to put it in. So that's the only thing. So anatomy, so that the chickens are really good for feel, but they're not so good for anatomy placement, right? Because it's probably going to be like, I don't know, you just sort of have to get in there and find a spot that's good and then practice the technique. I always end up doing this
That's okay. Yeah, it's better to do
touch the
that.
chicken.
So many chickens.
Okay, so we can all practice that and we can just go over that because that one's just, it's like, you just need to practice it, not so much of the procedure. Okay, so you've decided that they want you to put this pigtail in before they transfer the baby. The baby's stable. You're obviously going to get your team. You're going to get consent from the parents. The big thing that I find we really noted with our team that we forgot was pain control in these guys, right? So fentanyl is a great option, and that I think is what the children's protocol recommends. I think they even have dosing in that.
Yeah,
area.
so the really nice thing, so we actually, I'm working on, oh no, this isn't what I want.
I think this is the one.
This is what I want. I am working on adapting the BC Children's procedure for pigtail insertion for the island. And one of the really nice things about it is that it just says order and administer analgesia, and it gives you a dose, either morphine 100 mics per kilo or fentanyl 1 to 2 mics per kilo. And it's just like an IV push fentanyl slower, obviously, because of the chest freezing.
Because you don't want to get rigid chest.
Yeah, but it's like it's right in there, and the doses are right in there, and you just can't miss it really. And it really is a 2-person job. Like you're gonna have 2 people that are sterile.
For the
So your
insertion.
nurse or your helper is going to be sterile, but ultimately the line is far less traumatic than a trocar. It leaves less
Yes.
scarring, and it has like less chance of perforating things inside, which is
And once you've
handy.
done it a couple times, it's actually, and it's funny because actually when you're doing it, you're almost doing it like 3 times the whole procedure. So I feel like even just practicing it once, you get super comfortable.
Yeah.
Do you locally infiltrate as well? then?
Yes, as well.
Okay,
Yeah, as well with local. Yeah, so and you know it is two people sterile, but I think you almost also need that third person.
You do.
So
You
you
need
lots
like a
of
runner.
hands on board.
Yeah.
Because you're always gonna.
Don't
yeah.
worry, we got a ton of extra nurses. Without
Yeah.
No one's ever been.
That's
okay, Sarah can come up.
I mean, the other thing that we would have set up is like along with our chest tube add-on pack, we open up an umbilical tray. So the umbilical tray is our sterile field for the procedure, and it has all the instruments that you sort of would maybe need as well, and then everything sort of like the whole thing would be prepared before.
So you've got your
sterilely.
You've got your pigtail, you've got your chest tube add-on, you've got your umbilical procedure tray, and your meds, right? Like probably your four things you have, and your team.
Yeah.
So you talk to parents, you've got consent, you've got all your stuff,
Yeah.
you've confirmed your dose of fentanyl, you're gonna add some local, baby stable. Yeah, I think that's, yeah. So in terms of the actual procedure, and Lisa just like interrupt if I need. So I think step 1 is positioning. So obviously as the main inserter, you wanna be on the side of the chest tube that you're inserting. If you're good with chickens, this chicken is upside down. Your baby obviously is going to be face up, but it's easier to insert in the back of the chickens because their lungs are posterior. So anyways, imagine our baby's lying here. It's nice sometimes if you, I'll just put this underneath, but you can roll and get them up a little bit. Sometimes that helps with positioning. Yeah, I think that's sort of, yeah. So then, now I'm gonna scrub and be sterile. Got all my stuff out. So the first step obviously is to clean. Yeah, we can pretend to clean. I don't know if you have any comments on.
Yeah,
what
if
to
the
use.
if the baby is not really premature, then we will use the wipes with alcohol, or they'll use what's that pouring stuff that these
Iodine?
women? Yeah,
Yeah.
no, the other one.
Chlorhexidine?
Yeah.
I think, yeah.
Yeah,
I'm wondering about the cleaning because we were told with Acorn to use the ones without the alcohol.
Yeah, so we have
The
those as
green,
well.
yeah.
Green swabbies. They are also a part of our pack. Yeah.
So, but in this scenario, you would do a little alcohol, or can you still use?
Yeah, like so BC Children's uses, or BC Women's uses like their pouring solution with alcohol. Like these are considered non-sterile, which sort of is a little bit comical because they're swimming in a sterilizing solution.
Yeah.
So technically, if you were to do this, you would double glove. Like if you're being
Sterile.
real technical,
Yeah,
double
sterile.
sterile glove.
Uh-huh.
And when you pull these things out, you are then doffing your first set
You
of
alternatively could clean and then scrub and then sterile, right? Like
You
yeah.
could.
But
Yeah.
but I also think like I feel comfortable that they are probably fine.
Yeah.
Yeah.
They're in a sterile solution. How can they not be sterile?
Yeah.
But yeah. Okay. So positioning, cleaning. You do it 3 times. Infiltrate local. I don't know if we feel like we need practice. Why don't I talk about where we're going to put it in?
Yeah.
Because that's important. So you're going the anterior axillary line, 4th or 5th. So again, not really accurate on the baby. You can imagine in the baby, it is approximately the nipple line, but obviously the nipple is not fixed. So it, you know, I don't know if you had a saggy nipple on the baby, it might be too low. So sort of 4th to 5th, just finding a good spot in the anterior axillary line. Yeah. And then, so then you can infiltrate your local there. You gotta obviously infiltrate local into the skin as well as into sort of the subcutaneous and muscles. Oh, yeah, sure, awesome. So I sort of have my idea of my position. We've cleaned. You're gonna just pierce the skin, infiltrate a bit of local, go a little bit deeper, you know, sort of to the edge of the rib, and infiltrate.
How often are you guys doing this at NRGH? Like, is this
Well, since-
still
No, not often.
No, okay,
Yeah,
okay.
like
Yes,
before
yeah.
we taught it,
Yeah.
there had been like a run of 3 or
Of
4
3.
in like 6 months.
Wow.
Yeah.
And like knock on wood, since then we
Yeah.
haven't.
Okay.
And I do think it's because there was that problem with the Neopuff.
The dragger. No, not the Neopuffs, the dragger.
The
units.
draggers.
Yeah.
So I don't know, that's sort of my theory as to why we all of a sudden had more. But it was good because then it's sort of, yeah, so not very often, but I would say maybe on average, do you think maybe 1 a year?
Maybe 1 a year.
Okay,
Maybe.
yeah, okay,
Yeah.
sounds good.
Yeah. Okay, so now we've got the baby. Obviously, like, you know, a timeout, right? Just sort of confirming, hey, okay, we've got this right-sided pneumo. We're going to insert a pigtail catheter. We've talked to the parents. The baby's sedated. We've got all our equipment. Yeah.
Pretend that's a 10 mil.
Perfect. Okay, so then first things first, you're going to take your needle, right? And so just a regular old needle. If you, we decided no
Yeah.
stopcock on it. Yeah, okay. So you're going to put your needle on it. The benefit of, oh, and this has got, it's got,
We'll use one of those sterile Posiflush, like the 10 mil sterile ones.
Oh,
for
yeah.
the field.
with
Yeah.
syringe, with saline, right?
Saline, yeah.
And the benefit of that is because then you've got, so you're not going to inject it in, but when you're aspirating, you can see bubbles in there. So it's a really easy sort of marker. Yeah, so that's why it's like this, as if we've got saline in there.
Okay.
So then the good technique, right, is sort of, because you want to be, you're going to aspirate as you're going with this and holding, sort of positioning, stabilizing with your left hand. Well, if you're right-handed. Other way if you're the other. And I think holding your fingers around 1 centimeter to the needle so that you feel in control. And then, yeah, so you can like check again, okay, find a spot. And again, just in the chicken, you just want to find any spot that feels good, but we're 4th, 5th, anterior axillary line. And you're gonna insert, you want to just go in into the skin, sort of get yourself into the skin, and then you can aspirate as you move in towards aiming sort of anteriorly towards the opposite shoulder for a pneumo, and aspirating as you go so that as soon as you get bubbles, you can stop and you're in good position.
That's great. Yeah, I
Yeah.
like that. And of course, just right above the rib.
Above the rib,
right?
correct.
Just like,
Yes,
yeah.
yes, exactly. Yeah. So now this is where it's really key sort of to have your partner and communicate with them, because it's like you need extra hands. So I'm going to say, Lisa, can you hold the needle in place and then take this guy off? So then we're going to take our wire and pulling this all the way to the tip. You're just going to stick this, and so Lisa's going to hold that in position.
And then, Kelly, sorry,
no,
did
perfect.
You, I mean, the chicken maybe doesn't have any. Did you get bubbles? I didn't see that.
Well, I
like
did.
a
Yeah,
little
yeah.
bit? Okay.
If we actually get some syringes, you
Yeah.
can try that technique. 'Cause
Okay.
you
You'll get bubbles,
and you'll
yeah.
get
Okay.
bubbles. Yeah, but
Okay.
so I didn't, because we didn't have the
Okay,
right thing.
yeah.
Yeah. Okay. So then, see, we've got the little curve at the end.
Yeah.
So you're gonna just pull it so that it's straight, right? That just helps you put it in, and then you're gonna insert it in. Lisa's stabilizing it so that I'm not shoving the needle in further, and I'm going to, and so I like to feed this out a little bit, because this is your 10 centimeter mark, and what you're trying to do is get that into the hub of the needle, approximately.
Okay.
And so you're just gonna insert, and it should just go easily with no resistance, keeping an eye on that guy, so knowing, okay, there he went through there, and so knowing I have to push about 1 more centimeter. And then, that's a good point. Lisa says you can like see it go because you can move this back, because this was just there to guide the curvy end into the needle. So then you're just going to insert it until it's in the hub. And this is a part of just sort of being mindful of, is because then we're going to take this whole thing off the guide wire, because the guide wire is there to be our pathway into the right spot, right? So obviously this guy hanging around can be a bit dangerous. So next step, we need to take our needle off. So this is good, yeah. So Lisa's gonna hold the wire, and then I can switch hands and sort of loosen the needle. And then now she's gonna hold down there and take this guy off. So now this is he's just our marker for where we're trying to go. And so this is in there, it's got the curve on the end, it's just sitting in the chest wall. It's not poking anything because it's curved. The next step is to use your dilator. This is just gonna go on the tip here. So So you're just putting it over. Again, this is just our marker of space. Sometimes you might, if the baby has really like thick skin, you may need to nick to open the skin a little bit, right? Because, so then I would say, Lisa, can you switch over? And Lisa can hold this. Like, it's kind of always good to just give your assistant something to hold, because then she can sort of keep this in the right position, so I'm not, because I'm gonna push this into the skin. And you wanna get it through the skin. This is just dilating skin and subcutaneous tissue.
Thanks.
right? So you might sort of, if it's tight through the skin, you might twist a little bit, but you're only going in like 1 or 2 centimeters. This doesn't have to go all the way into the lungs. This is just opening up your sub-Q tissue. Yeah, so then it's just gonna sit there, sort of dilate, you can make sure it's good, and then you're just taking that guy off again. Yeah, similar to Lisa, you see how she's like, so she's like she's the anchor. Yeah.
And Kelly, just kind of like, central lines, a similar
Yes,
technique.
absolutely.
You kind of mentioned with a lot of subcutaneous, you have to make a little nick. Do
Yeah.
you find a lot of the times you don't
No,
have to?
no,
with
I don't
this?
find,
Okay.
because often their skin actually isn't that tight. I mean,
Okay,
you definitely don't
yeah.
with a chicken.
Especially in that area
Yeah,
of their bodies,
yeah,
I feel like,
yeah.
too. It's pretty
Yeah.
thin and...
Yeah, that's great. Yeah.
Yeah, and you could either do it when you just have if you were going to open up the, or you could do it when your dilator's in there, because even if you snip your dilator a little bit, like it's not gonna,
Yeah.
it's just there to make space. So then again, we're still good. We're gonna, this is our chest tube, right? So this is our chest tube, nice little pigtail. So that's because it's just gonna sit in the chest cavity and not poke into anything. It's got, it's very curvy, and it's got these drainage holes that you just need to pay attention to. Oh, and this one doesn't have markings.
Weird.
Interesting. Okay, so thinking of how far you're going to put it in, obviously you want to make sure all of these guys get into the chest wall. And then they usually have markings on them, and basically you want to get past the first marking. But if
You want,
all,
like, the full curl in.
yeah, if all you do is get those air guys in, that's also good.
Okay.
We're not neonatologists. Okay, so this is just finicky, right? Because it's just curvy, so you just have to play with it a bit, right? So you're just gonna, but you can't, yeah, so it's just a little wrestling with it.
Together.
And so again, Lisa's anchoring it there for us. So then I'm just feeding it on. Yeah, and I find you just sort of have to twist it as and so Lisa's holding it so that I'm not shoving the wire further in while I work with this.
Right.
And then again, she does her hand over technique to hold that, and then I can kind of take over here and insert. So this can be, sometimes I find it actually you need to sort of hold onto this yourself to gauge the pressure you're putting here. Yeah, and so then you're just inserting. Again, you can kind of, you can actually feel it go in quite well, right? So I'm just watching, pushing it in, making sure my holes all get in, maybe give it another centimeter after that. And then I can feel it, right? You'll be able to tell, you really feel it get in. Obviously don't play with it like that when it's in there, but you can get the feel of like, oh no, it's in an empty space. Yeah, and then you're just gonna hold onto the tube while you take the wire out. And now you're in place. And this is where these guys take over and tell me what to do now. You can, you don't have to, but you can suture it in. Again, kind of like you would do for a UV, right? Like a couple of purse strings with some, up here. But if you're not sure, just slap some tape on, right? Like this is like, if you're like, I'm happy, like just, you've got it in place, you don't have to.
So what they say first is like, so the Pneumastat has replaced the Heimlich. They don't make the Heimlich anymore. This actually is a regular stores item, so it's easy to get. It does exactly the same thing. It valves and it vents, but you can actually also like pull out if you have any liquid in here. But for neonates, like we generally don't. Maybe unless you have like a chylothorax or something, but even that is like so rare. I feel like when do you see those?
Ship it up to Victoria.
Totally.
Hardly ever, right?
They're on route by
So the nice thing with this is that, so before we dress it, we're just gonna attach it to the Pneumastat, and it like lure locks right in. It comes with these little connectors. Clip that to the bed, and then the way that we dress them is the way that BC Children's told us to do it. So, I don't know. We sort of, and it almost is like a two-person job. So like,
Yeah, here, why don't I?
our physicians don't generally help
I know.
us dress.
I'm like, I don't know what to
Because you're holding, you're anchored.
Yeah, so then this sort of is like a bit of a tuner. Yeah, let's go this way. This way? So we, we like sandwich it with the tegaderms.
Okay. It's almost like that little bridge that you get with the UV lines.
Yes, like the anchor, like
Yeah.
the goalpost, they call it. Yeah.
Oh,
Totally.
it is.
And then take off the
That's a
frames.
different little technique you guys did there.
We take off the frames and then we reinforce it again.
It never sticks well to the chicken.
No,
Chicken's a
the
bit
chicken,
difficult.
the
Yeah.
chicken
You
is
kind of put
so.
additional tape as you need to
Yeah,
on the
so then
face,
we
on the
like
foundation.
take what, a 2x2.
2 by 2, okay.
Yeah.
And then
And
we
then
fold it over.
Okay.
With another one.
And then we do like our
Yeah.
final.
Like a little.
Okay.
Yeah.
And so Kelly, do you suture it? I think we're just so
I think
used to doing that,
yeah.
eh?
I
It's,
think
and it's
I
not
just
sticking,
would-
of course,
no.
but
And
that's what it would
Take
look
a picture
like.
before you.
But I think if you're not comfortable,
Yeah.
don't. But if you're like, oh, it's like you're used to
Well, I can
putting
get it standing up, that way I'll remember the,
Normally,
and then if you push it down.
Chicken skin
Yeah.
doesn't work
No.
enough.
No,
I
it's very
talked to-
moist.
I can't remember
Thank
if it was
you.
Victoria or Vancouver, and
Yeah.
the nurses definitely appreciate when you suture
When you
them in.
suture.
So I think
Oh,
I was
they
like,
do like it,
yeah,
okay.
because they think
Especially
they
for
find these guys
transport.
slip out.
Yeah.
Yeah, secure.
Yeah, these little critters for us
secure with
are all
the- with
going
the
out,
little-
right? We're
So
not
they're
gonna
Yes,
do-
exactly.
They're not gonna
Yeah.
sit down.
Yeah.
Okay, well done, that's
Like
great.
that.
That's really slick.
Yeah.
Do you guys want to practice on it?
Yeah, yeah, totally, I'd love
Get you
to.
reset
So
up
is this
here.
the syringe you're talking about, this the one with
Yes,
the same?
yes,
Yeah,
yes.
so you
Yeah.
guys can, and it will actually work in the
So
chicken?
Kelly, I
Yes.
think the only difference, you know, obviously, I don't think anyone uses a trocar. It's such a waste of like metal because
Yeah.
everyone just chucks them. So instead of like this, which is great, I think we would have just probably in the past just dissected with a little knife,
Totally.
you know.
Yeah.
But this is really slick. I
Yeah.
have to say that was
Yeah,
really
like it-
slick.
Yeah.
Well
it's-
done.
Well, and I think also, especially like, well, I feel like trainees who have gone through, right? Like it is the same that, yeah, you put other stuff in this way, right?
Yeah.
Like central lines in the
Yeah.
intensive care unit, which hopefully we're not doing
You just
anymore.
don't do very much. That's the problem.
No,
you know,
totally,
it's
totally,
a
yeah.
technique that you just don't do very
Yeah,
much. so,
totally.
yeah.
All right.